Good evening, all. When it comes to STEMI diagnosis, even in difficult subsets, the ST elevation on the standard 12 lead ECG is the mainstay of diagnosis. The physiological substrate we know is an acute thrombotic occlusion, a complete occlusion of one of the epicardial coronary arteries that need to be urgently reperfused. But not all acute thrombotic occlusions would have definitive ST elevations. In fact, without definitive ST elevations, we call them subtle STEMIs. The sensitivity for conventional ST elevation definition that was alluded to by the previous speaker to diagnose an acute thrombotic occlusion is 85% for LAD, 75% for the RCA territory, and a mere 50% for LCX, the electrocardiographically silent territory as we call it. One third of patients in another study without ST elevations had a critical culprit lesion on angiography, either a 100% ATO or a 90% stenosis with less than TIMI-3 flow. One other study from yesteryears based on positive CKMBs, a negative ECG was seen in 43% of the cases of ACS, which means what? In 8% they were completely normal, and 35% the ECG was non-specific or non-diagnostic in spite of acute thrombotic occlusion. 20% of these negative ECGs later on went on to show frank ST elevations. Remember, non-diagnostic ECGs might be subtly diagnostic to a more expert clinician. So the first part of the talk will concentrate on the subtle STEMIs or non-diagnostic ECGs wherein there are no definitive ST elevations. And the second part of the talk would involve patients with ST elevations, not necessarily ischemic. And how do we go about diagnosing STEMI in such patients or differentiate them from STEMI? 60-year-old gentleman with cystic fibrosis of the lung presents with chest pain of 12 hours duration, and what do you see? Hardly any ST elevation in the ECG. If at all, subtle ST depressions in V1 to V3, where there's also a positive tall R wave. Later on admission, the ST depression has almost disappeared, but there is still that tall R wave. Last year's ECG clinched the diagnosis, or rather prompted us to take him immediately to the cath lab. No R wave here in V1, unlike the acute event ECG. And lo and behold, a thrombotic occlusion of the circumflex that was immediately stented, reperfused. So ST elevations are hardly to be seen in a standard 12 lead ECG of isolated posterior wall MI. And what you need to do is that take additional limb leads, precordial leads V7 to V9 to diagnose it. And that qualifies for reperfusion therapy by the new guidelines. Now, very ominous ECG, another gentleman has got generalized gross ST depressions in more than 6 leads. As also has got an ST elevation on AVR. I know what you guys are thinking about. Isn't this left main? Yes, severe coronary artery disease due to left main is one of the causes. The other causes being severe triple vessel disease, and a proximal LAD anterior wall infarction can also have ST elevations in AVR. Other causes: subendocardial ischemia coming from sustained tachyarrhythmia, shock or profound hypotension, GI bleeding, anemia. We need to be aware of all these causes. Anterior wall infarction, as you can see here, with an ST elevation in lead AVR. Where is the thrombotic occlusion? Well, you must remember that the additional ST elevation in AVR does not represent a left main ATO and is not helpful in diagnosing infarct-related artery or the site of occlusion. In fact, less than 3% of anterior STEMI have a left main ATO, and most are recognized clinically because of cardiogenic shock, and most do not even make it to the cath lab. Our patient, thrombotic lesion in the proximal LAD, also has left main disease, which is of course significant here. Now let's move on to T wave changes, the hyperacute T waves, the De Winters T waves, and the Valence T waves. 30-year-old smoker with pain since just 30 minutes and presented very early. These ST elevations, what do you think? Are they early repolarization? Compare this with another 34-year-old male with chest pain. Angiographically was shown to have ST elevations due to an early repolarization. And what do you see in early repolarization? Is that you get these tall T waves, yes. You see upwardly concave ST elevations across the precordial leads, an early transition of the R wave, and a distinctive J point. So these are the classical changes. Add to it hardly any reciprocal changes in the inferior leads. So this is not anterior MI. So coming back to our patient, what do you see in him? Hardly any J wave or an S wave in leads V2 and V3, and a terminal QRS distortion suggests that the hyperacute tall T waves. This patient was thrombolized with immediate success given that he presented so early. Now here you can see in another patient, hardly any ST elevations here, just a mere ST depression in AVL as well as T wave inversion in AVL. That should make you look at leads 2, 3 AVF. And what do you see? Hyperacute tallish T waves. These are hyperacute inferior T waves. When in doubt, as in this case, again you have to the subtle eye, there is no doubt that this requires reperfusion. ST depression in AVL and in 1. And what do you do at this stage? 15 minutes later, very overt ST depression. Not only that, the hyperacute T waves, good enough reason to proceed with reperfusion. However, if you wait for another 15 minutes, which is not necessary, you start getting the ST elevations. So early presenters is what hyperacute T waves is all about. Large, bulky, wide, disproportional to the QRS. That's how these T waves look. And subsequently, you may get an increase in QT interval. Often they are asymmetric, localized to the anatomic region of the infarct and cause a decrease in the QRS amplitude, unlike the repolarization where the R wave is really tall. Now, another patient here, again, you see ST depressions in inferior leads. You see tall T waves, V2, V3, V4. They are symmetrical T waves, as also ST elevation in AVR. But very important sign here, which is the De Winters sign, is that in the precordial leads, there is hardly any ST elevation. If at all, there is an upsloping more than 1 millimeter at the J point, ST depressions that you can see. So this is the De Winters sign, which is seen in about 2% of all anterior myocardial infarctions, and associated ST elevation in lead AVR is also shown. When in doubt, a bedside echocardiogram shows the typical regional wall motion abnormality in the anterior territory. Another patient, again the T wave change here, no ST elevations, but V2, V3 are showing biphasic T waves, which are called as the valence type A, which go on to evolve into valence type B, deep symmetrical inverted T waves. And Valence said that this was highly specific for critical proximal stenosis of the LAD, and in his own words represents a pre-infarction state and a delivery boy of bad news of impending anterior wall MI. That's what this ECG is. Let's now move on to STEMI mimickers or the STEMI imposters, who also have an ST elevation but not necessarily ischemic. They could be pre-existing or could acutely occur as in acute pericarditis or Takotsubo cardiomyopathy. Now, left ventral branch block, ventricular pace rhythms and LVH, all of them have pre-existing ST elevations. But what when they come with chest pain? How do you go about diagnosing that? Here is a gentleman who has got an LBBB, clear-cut LBBB with ST elevations across here from lead V1 to V3. But what is important is you see the concordant change in leads with positive QRS, that's leads 1, AVL. V5 and V6. Any ST elevation more than 1 millimeter here is said to get, in terms of Garbosa's criteria, 5 points. And here you can see concordant ST elevations of more than 1 millimeter, 3 points for ST elevations more than 1 millimeter in when it is in the concordant ST depression, and a discordant leads, you anyways get ST elevation, so at least 5 millimeter ST elevations in discordant leads gets a score of only 2. And in a meta-analysis of 2100 patients, documented that a score of more than or equal to 3 has a specificity of 98%, but a sensitivity only of 20% for the diagnosis of acute myocardial infarction. Which is the culprit artery here now? Can you figure out? Generalized ST elevations, concave upwards ST elevations, pretty gross for that matter, except for ST depression in lead AVR. This patient was picked up in the corona ward, and actually, beside the ST depression, you are supposed to notice PR depression, which you'll see in the next ECG, in another kind of a acute myocarditis during the corona infection in the ICU. Now, here is a patient who has got concave upwards ST elevations leads to 3 AVF. Why is it not an inferior wall MI? Is what you might think. Please notice here the concave upwards ST elevations is also a PR segment depression that you see, and in fact in lead AVR is the only lead which is showing an ST depression but also showing an PR segment elevation in AVR. So this patient, on an echo and on the basis of a typical history of fever and pain going on for a couple of days, was diagnosed on the basis of an echo, a localized posterior pericardial effusion. How do you differentiate it from the inferior wall MI? Well, in acute inferior MI, 99% of the time, there is a reciprocal ST depression in lead AVL, which we showed you also when I showed you the hyperacute T waves. Now, stress-induced cardiomyopathy or the Takotsubo cardiomyopathies may have ST depression, T-wave inversions, as also ST elevations at presentation. And you can never tell whether this is an infarction unless you have the true ASCVD infarction, that is to say, unless you have done a coronary angiography and shown clear coronaries. During the stress of corona, this was reported with an hashtag Coronatsubo also. So in conclusion, ladies and gentlemen, standard diagnostic ECG criteria have limitations. A careful detailed history and examination helps to differentiate various causes of ST elevations. When in doubt, always compare with the previous ECG. Repeat serial ECGs every 10 to 15 minutes. Record additional leads V7 to V9 for posterior MIs. An electronic transmission in the form of WhatsApp for a second opinion helps. Echo imaging for new RWMA and cardiac enzymes are additional tools. However, blood sampling for cardiac enzymes should not delay reperfusion. And when in doubt, nothing like an urgent cath lab call for diagnosing acute thrombotic occlusion and performing a primary PCI. Remember, all ST elevations in ECG is not STEMI, and all STEMI do not have ST elevations in a 12-lead ECG. Thank you for your attention.